So as you guys know, I have come down with a cold. Fortunately, it doesn't seem to be too awfully bad, and I think by Thursday I'll probably be back in class again. I just feel like I'm still really contagious and really don't want to spread my germs around to everybody. So we're going to pick up where we left off on Thursday with um, the GI topics, and then I'll send you another link that will give you the GU topics as well. On Thursday, we should be able to have some time that we can ask questions and get some information about the test, and hopefully by then I'll have the test blueprint made as well. So let's begin. Hirschsprung's disease is also known as congenital aganglionic megacolon. I want you to really think about that term when we're talking about it, because what's really going on in it is the absence of ganglion cells in the colon. They don't have the nerve cells necessary for the colon to respond appropriately to the peristalsis. So what ends up happening is we have a mechanical obstruction from inadequate motility of the intestine, and the incidence is about 1 in 5,000 live births, which is a fairly common disorder. I've seen quite a few of these over the years. They're more common in males and also with children who have Down syndrome. So the big problem that happens with them is there's an accumulation of stool with distension, and this is because there's a failure of the internal anal sphincter to relax. So if you think about it, what happens physiologically is we have an internal sphincter and we have an external sphincter. Most of us think about the external sphincter, but really as we get older, the internal sphincter is what we have control over, that keeps us from just passing stool all the time. And so we cause that to relax and we stool. And once that internal sphincter relaxes, it's very difficult for the external sphincter not to relax as well. In these children, we may actually see enterocolitis appearing as well, because again, the stool isn't passing through, so we get an inflammatory reaction in the bowel. In the newborn period, what we see is a failure to pass meconium within 24 to 48 hours after birth. Because nothing is passing through, and it's just sort of building up on top of itself, these kids don't feel hungry, and so they may refuse to eat. In addition, when we think about vomiting, the more bilious the vomit, the more there's an obstruction below, and so things are backing up. So in these kids, things are backed up because there's an obstruction at the anus, and so these kids have bilious vomiting. They also have abdominal distension from this bowel being over distended. In infancy, what we see is a failure to thrive, constipation, abdominal distension, episodes of diarrhea and vomiting, symptoms of enterocolitis. They may have explosive watery diarrhea, fever, and they appear significantly ill. In childhood, we see constipation, ribbon-like, foul-smelling stools, so very thin stools, abdominal distension, visible peristalsis, and an easily palpable fecal mass in that stool, in that portion of the bowel. In addition, we'll see almost the rest of their body. They may have this big belly, but they have the rest of them appears undernourished and anemic looking. So you might say, why didn't they catch it when they were newborns? Well, it could be that there were just enough ganglion in their bowel that they had their stool within 24 to 48 hours, but it's not normal. And so there's variables within Hirschsprung's disease depending on how much of the bowel is lacking in the ganglion cells. Remember, A in front of a word means there aren't any. So there's a portion of the bowel that doesn't have any ganglion cells, but then other parts do. So how do we diagnose it? We may do an x-ray or a barium enema. Often we don't necessarily do a barium enema, but we do use a contrast material. Again, this kid is already backed up. We don't need to be sticking stuff down there that's going to turn into a rock. They may do an anorectal manometric examination where they actually measure pressures of the muscles of the sphincter. But ultimately, they're going to, they may have suspicions that this is Hirschsprung's disease, but the diagnosis, the gold standard of saying that somebody has Hirschsprung's is to do a rectal biopsy looking for ganglion or the absence of ganglion cells. So normally what they do is they do several biopsies, starting at the most distal area of the bowel and then going up farther into the bowel until they get to a place where they have ganglion cells again. Treatment for Hirschsprung's is surgery, which is a bowel resection of all of the ganglionic bowel. So if there aren't any ganglion cells in that section of bowel, it's removed. Preoperatively, these kids are NPO. They are on IV fluids. Usually they're on total parenteral nutrition so that they have good nutrition prior to surgery. And we're going to be monitoring their blood sugar, their electrolytes. We're going to be monitoring them for pain. And also they'll probably have a NG tube down to suction so that we can decompress the bowel. After surgery, initially when they come back, they'll still have that NG tube down for decompression because now we have swelling below. And so that has to calm down some. They usually will have an ostomy as well. And so we'll be concerned about pain, respiratory management, and watching them for signs that the bowel is starting to be less edematous and fluids are moving through the bowel. Normally there's 2 stages of surgery. In the first stage, they put a temporary ostomy. Those are in cases where they think that they may be able to do a primary reanastomosis later on. And the second stage is a pull-through procedure where they anastomose the bowel together. So the area that had ganglion cells, maybe from the anus up an inch, they would take that and attach it to the area up higher where there were ganglionic cells and connect the two. Usually during that time, they connect that bowel, but they continue to have the ostomy initially. And then the ostomy is closed at a later time. when we look at things like Crohn's disease and ulcerative colitis, we're looking at what's known as inflammatory bowel disease. And in these cases, it's very painful, and children will choose not to eat because they have abdominal cramping, they have nighttime symptoms that include waking up because of abdominal pain or an urge to stool. They may have fever, they may have weight loss and poor growth, as well as delayed sexual development. Usually we try to manage these with medications, although in some cases the inflammation that's involved in the bowel may require them to have surgery and some bowel resection. However, usually that isn't necessary, but it's definitely one of those chronic diseases where they have periods of not having any symptoms and then relapse periods where they have severe symptoms. They kind of go back and forth, but they never know when they're going to come. Celiac disease is not the same as these inflammatory diseases, but yet on some level there's similarities with it. It's also known as gluten-induced enteropathy or celiac sprue. It is a permanent GI intolerance to dietary wheat and any related proteins. The four characteristics of celiac disease is steatorrhea, which is a fatty stool, general malnutrition. So look at this picture of this child. It's got little skinny thin arms and legs and a distended abdomen. Also, there may be secondary vitamin deficiencies associated with it as well. The symptoms include diarrhea, constipation. Yeah, you could have one or the other. Failure to thrive or weight loss, abdominal distension, irritability and listlessness, dental disorders, anemia, delayed puberty or amenorrhea. If you don't have good nutrition, you don't have periods. And it limits the amount of hormones that are being produced, which affects the signs of puberty. Also nutritional deficiencies. The pathophysiology is that they're lacking the enzymes necessary to digest wheat and gluten, and there is a genetic predisposition for it. Diagnostically, they may do lab work to look at inflammatory markers related to this lack of enzymes. They may also look at other symptoms like doing an endoscopy to see the inflammation of the esophagus or the upper bowel. Therapeutic management is to avoid foods with gluten in them, which sounds like it wouldn't be all that difficult, but it's a little more difficult than what it sounds like. There's a lot of considerations as far as nursing is concerned, as far as family support and education. There's a tremendous amount of education involved. I had a friend that I worked with in the NICU. So she was a nurse, and her children, she had 2 children that were showing symptoms where they would have just horrible abdominal pains, lots of headaches, lots of other problems health-wise, and they just never could seem to get answers to it. And finally, one day, the doctor decided to rule out celiac disease and found, after doing the workup on them, found that both kids had celiac disease. She has 5 kids. So 2 out of 5 definitely had celiac disease. Because there's a genetic component, they tested the rest of the family and found that the entire family had celiac disease. They just had variable symptoms associated with it. One of the things that she said that was difficult for her with the new diagnosis was changing the diet of the family. Now, whether the family would have tested positive for celiac or not, the whole family would have changed to eating this gluten-free diet because it's too difficult to cook one way for part of the family and another way for another part of the family. And so it has to be a family decision that everyone's going to be involved in the diet. She said it was difficult to get used to the type of cooking that was involved. If you think about it, there is no birthday cakes. You can't just go down to Kroger and pick up a birthday cake because the flour in cake is wheat and has gluten in it. You can't just go and pick up a package of oatmeal because oatmeal may have been processed in a factory where they process flour, and so the machinery may be contaminated with gluten. And so whenever they purchase anything, they have to read all of the labels. And if there is something on it that says may have gluten, maybe, there may be gluten in it, even though it's something that shouldn't have gluten in it, like cornmeal, then they can't buy that one. They have to go get a package that says gluten, 100% gluten free. So it's difficult. And when the child is invited to a birthday party or something like that, the child can't eat birthday cake. There's a lot of things involved when children have disorders that affect what they can eat. And so there's a lot of education that has to be done for both the family that's going to be purchasing these food items and preparing them, but also for the child so that they can understand what their disease process involves. And of course, follow up, these kids are undernourished usually to start out with, but after a change in their diet, they often are having no difficulties at all, but it's important to follow up and make sure that they're getting good vitamins and they're not having other side effects. There are several long-term health conditions related to celiac disease, including iron deficiency anemia. Obviously, we can get iron from other sources, but we probably get a lot of our iron from fortified breads because that's one of the things that's put into bread. Also, there may be onset of osteoporosis and osteopenia, so they have to be monitored for that. They may have infertility and miscarriage later when they decide to have children. Lactose intolerance also goes along with celiac disease, and so they have to be careful and make sure that as they're doing their workup that they don't have that as well. In addition, there may be vitamin and mineral deficiencies. Again, a lot of our foods that are associated with bread and flour, the flour has been fortified with additional vitamins. We have central and peripheral nervous system disorders, pancreatic insufficiency, intestinal lymphomas, and other GI cancers. That's related to the fact that there is a inflammation of the bowel, And when there's chronic inflammation of any part of the body, it increases the risk of cancers. There may be gallbladder malfunctions and neurological manifestations, including ataxia, epileptic seizures, dementia, migraines, neuropathies, myopathies, and multifocal leukoencephalopathy. So moving along, now that we've talked about gluten intolerance, well, now we're going to talk about lactose intolerance. And what it is the inability to digest lactose in milk due to deficiency of lactase production in the body. The symptoms occur after eating dairy foods and include diarrhea, gas, and bloating. Gas and bloating being the two most common symptoms. The risk factors include increasing age. The older we get, the less lactase we make. So if you think about it, when we're babies, we're meant to drink our mother's milk. And because we're meant to drink our mother's milk, our body produces lactase to digest it. Well, after we reach a certain age, we really aren't supposed to still be drinking our mother's milk. And so the body starts to decrease the amount of lactase that it produces. And the older we get, the less lactase we produce. So it's not uncommon to see that people that were able to drink milk and eat ice cream and do all of that, as they get older, they start having these symptoms of gas and bloating and diarrhea whenever they eat dairy products. We really are the only mammalians that drink milk past infancy. And in addition, not only do we drink milk past infancy, but we drink another species' milk. So it's, if we look at purely what we ought to be doing, we ought not to be having any dairy in our diet at all. And in fact, this whole milk, it does a body good. We've actually have research out there now that shows that milk does not do a body good. It actually causes some of the osteoporosis that people have. So it's kind of one of those not so good. Ethnicity also affects, is a risk factor for lactose intolerance. So we know that Hispanics and African Americans have higher incidence of lactose intolerance, as do Asians. And it may be that as Caucasians, we're just not acknowledging that we have it as well because we like our ice cream. Premature birth increases the risk factor. Diseases that affect the small intestines, because that's where lactase is produced, and certain cancer treatments may increase the risk factor of being lactose intolerant. The diagnosis is done through the lactose tolerance test or the hydrogen breath test, which looks at how the body is or is not breaking down lactose. And they can also do a stool acidity test, because when lactose isn't digested fully, the acids are much higher in the stool. Finally, the big treatment is you avoid dairy products, just like with celiac disease. You avoid gluten. With lactose intolerance, you avoid dairy. It's not as difficult now as it used to be because we have so many plant-based options that provide for just about anything that you can get in dairy. There's some really nice lactose-free plant-based ice creams that seriously taste wonderful. As somebody who's lactose intolerant, I didn't want to admit that I was lactose intolerant because I love my ice cream, and I couldn't imagine life without my ice cream. But yeah, I get the bloating and the gas when I eat ice cream, so I try to stay away from it. But now that there's coconut ice coconut milk ice cream and cashew milk ice cream, honestly, it tastes the same as ice cream. And the cashew milk ice cream is very rich and creamy, just like a regular ice cream is. It really tastes pretty good. The milks, if you're used to drinking cow's milk, they just do not have the same texture or the same taste. You can taste a little bit of whatever plant they came from. So coconut-based coconut milk has a little coconut taste to it. There's a banana milk, and yeah, it definitely tastes like bananas. And oat milk, I definitely taste the oats in it. The cashew milk has a nutty taste to it, and it definitely, like rice milk, is really thin, like drinking skim milk. And so I think when people have to change their diet, they have to think, instead of comparing it to dairy, they're going to have to look at it as being a whole different taste. Some of the plant-based sour creams aren't too bad. Some of the plant-based cream cheeses aren't bad, but the cheeses stink. They are nasty. They do not taste like cheese at all. And so, yeah, there's still some things that they need to work on, but it's getting better than what it used to be for people that are lactose intolerant. When we also look at hepatobiliary disorders, pancreatitis, gallbladder disease, jaundice, biliary atresias, hepatitis, cirrhosis, and portal hypertension, and ultimately liver transplant. We don't see that very often in children. And usually when we do see these hepatobiliary disorders, they're related to treatments for other diseases. We do get physiologic jaundice with children in the first 5 days after birth. There also is a type of jaundice that's known as breast milk jaundice, which also has to do with how the body digests the breast milk. But it's not associated with kernicterus. And then there's also ABO incompatibilities, which you should have learned about in OB, that affects the child with jaundice. We can get some biliary atresia and portal hypertension related to being, if they're on total parenteral nutrition for too long. And those kids, if they continue to need to be on TPN, can end up needing a liver transplant. But in general, these diseases are really more associated with adults than with children. Obesity, it's a ongoing problem, and I'm sure you've heard on the news and things like that how America is becoming fatter, and it definitely is affecting children as well. Obesity is defined as an increase in body weight due to the accumulation of excess body fat relative to a lean body mass. Obesity is defined as being at the 95th percentile for age, gender, and height. I think that one of the things that we have to consider is that there are people who are at the 95th or higher percentile for height and weight and gender and age, and they are not obese. It is just their genetics to be a large person. And when I say large, I'm not talking about being overweight, but being very tall and appropriate for weight with their height. What we're talking about here is somebody who's at 95th percentile of weight but their height maybe be 80 percentile for height, and their age, it's 95th percentile for age, but their weight is the weight you would see for somebody 2 or 3 years older than what they are. Overweight is generally considered to be when the weight is more than the 90th percentile. About 25 to 30% of children in the United States are obese. So it's really a problem that we have to look at strongly. Obesity has a lot of variables involved with it. For instance, there is a genetic predisposition in some cases for obesity. If you follow the family back generation, you see overweight people. I know I look at my own family, and on my mother's side of the family, there's a lot of obese people. On my dad's, there's not as many, but I can go back to pictures like 3 generations behind me, and these people were farmers. They were working hard every day. They didn't have all of the mechanisms that we have now for farming, and yet the pictures show them as being very large people, probably in the overweight area rather than the obese. And you just kind of look at them and say, how did they get so big when they worked so hard? And the genetics, that's what you have to look at with that. So what we see is if we have a predisposition for obesity, often the infant is also obese. The other thing that can make for an obese infant is the eating style of the family. One of the things that I see, and it kind of goes with this overfeeding thing with infants, is especially with bottle-fed babies, a family will sit there and they'll put, maybe the kid's been taking an ounce. So they put an ounce of formula in the bottle. And of course, you're not supposed to use that again, like when they get hungry the next time. So the kid is eating, and he only eats 3/4 of an ounce this time. Well, now it's like the family looks at it and they, formula is expensive and they don't want to waste. And so they kind of play around and they get the kid to eat that last little bit. Now, doing that every once in a while probably isn't the end of the world, but when you do that over and over and over again, so that you're feeding the kid more than the kid actually wants to eat, you're overfeeding them, and they will gain weight. And if we have an obese infant, that obese infant will turn into an obese child. With the obese child, they'll turn into obese adolescents because they don't tend to lose weight. They continue to maintain their weight. This can lead to metabolic disturbances like metabolic disorders. And additionally, they may be bullied because of their weight, and that can lead to psychological pain, which can lead them to using food as a comfort. And so that becomes a big chronic problem. Like, I feel better. Food is my friend. Food makes me feel better. And it can lead to social isolation. And if we have an obese teenager, we often have an obese adult. Some of the impacts of childhood obesity include an increase in type 2 diabetes, a risk for adult obesity, hypertension, hyperlipidemia, and cardiovascular disease. We're starting to see hyperlipidemia and hypertension in 6, 7, 8-year-olds. Up until this point in history, we've never seen these diseases in children. because children were out playing and they were out doing things. But with the sedentary lifestyle that our children are having and the high-fat diets that they're eating, we're starting to see hypertension and hyperlipidemia in these children, which is putting them at risk for cardiovascular disease at a younger age than what we've seen before. And then we talked about how it may cause social isolation, low self-esteem, and depression. In 5% of children, there's an underlying disease like hypothyroidism or other metabolic diseases or a central nervous system disorder. We talked about the role of heredity, inactivity. Our kids are watching TV, our kids are on the computer, they're playing computer games, they're not getting out there and running and playing like they ought to be. And then patterns of eating behaviors where they're eating high-fat, high-calorie foods also has increased the risk of obesity. When we look at diagnostic evaluation, we'll be looking at doing skin fold measurements, body mass index calculations, and body fat measurements, and other diagnostic tests to rule out metabolic and endocrine disorders. If I have a child who has been following their normal growth curve up until this point and suddenly becomes obese, I need to make sure that I'm not blaming the obesity on the wrong thing. And so we're going to look at other metabolic disorders and rule those out before we say, oh, it's just because you're not exercising enough or you're eating the wrong foods. So going the opposite direction, we have anorexia nervosa. I'm not going to spend a lot of time on this because you had this information in psych, but it's a eating disorder that involves refusal to maintain a normal body weight. It often has some characteristics of control issues where the child doesn't have control in anything else in their life, but they can control what goes into their mouth, and so they do. Is primarily seen in adolescents and young adult females, although my daughter, when she was in school at Dunbar, had several friends that were males that had both bulimia and anorexia nervosa. So I think that one of the things that we see is we make an assumption that only females are having this, when in actuality there's males that are experiencing the same issues. The mean age of onset is about 14 years of age, but it can range as young as 10 to 25 years of age. I've heard of a few cases where it was 8-year-olds. One other aspect of anorexia is that if you grow up in a household where the people in the household are always on a diet, and you start seeing yourself starting to gain weight, you may decide that I'm not going to be like you. I don't want to be fat. I don't want to be on a diet all of my life. I'm just not going to eat. And so that's another aspect of this disease. It is a life-threatening disorder because it does affect the electrolytes in the body. And although anorexia itself is more of a not eating type disease, it definitely is related with bulimia. And those types of disorders really mess up the electrolytes. So some of the things I can remember, people that I knew that were gaining weight saying, I wish I had a parasite, because then the parasite would eat up all my fat-causing food and I'd be thin. But no, we don't want to have intestinal parasites. Helminths are worms, and we don't tend to see these big, long tapeworm type things here in the United States, but we do see pinworms. And we may see protozoa like Giardias, especially like people that go hiking up in the mountains and then drink out of the streams without purifying the water, because we know that the animals don't care. They go drink and poop at the same time and contaminate the water. So these are things that children may pick up over time. So our nursing priorities is to assist with identifying the type of parasite. When we're looking at pinworms, pinworms like to live just inside the anus, but they come out at night, which is why the people talk about how itchy it gets at night, because the pinworms are coming out at night out of the anus. So we don't want to get we don't want too much light there, because if you shine light on it, on the rectum, then the worms will go back inside. So we try to get in there and get out, get there, get it done. So we kind of prepare everything in a semi-dark environment. And then we may shine a light just long enough to get the worms attached to tape, and then they get sent down to lab to say, oh yeah, that's what it is. And then we can treat it. We want to assist with education and treatment and anticipatory guidance. So basically, how do you keep from getting this? Once they have them, what do you need to be doing? Making sure that you're washing linens frequently, making sure that kids are cleaning under their fingernails and not sucking their fingers, making sure they wash their hands, all of those things, not drinking water out of streams because it may be contaminated. Even though it looks nice and clean, it may not be healthy for you. And using, people that go camping a lot use filters that filter out these protozoas so that it makes the water safe for them to drink. But they have to know that it's not just any old filter. It's a special type of filter that you use. Some of the psychosocial concerns or interventions for children with GI disorders. Kids that have GI disorders are considered to be medically fragile for a very long period of time, because our digestive system has a lot to do with our immunity, has a lot to do with our ability to grow. There's a lot of anxiety related to bowel resection. It's scary. I mean, that's all you can say. It's a very scary thing to go through. And to think that your child's bowel is going to be cut and it's going to be coming out an ostomy. And what if the bag doesn't stay attached? And what if there's a leak inside of their body? I mean, these parents worry about everything when it comes to things like that. Often the kids are in the hospital for long periods of time. And so the parents may have to miss work or spending time with the other children in the family. So that becomes a familial stressor. We want to encourage families to become the experts on their child's needs and condition, and by doing education and having them participate in their care. It is always good to give somebody the tools they need to become expert in their care or in the care of their child. And nurses need to not be insulted when a family says, oh no, you can't do it like that, because if you do it like that, it's going to leak. Like when we change an ostomy bag, those parents are experts. They know exactly how to do it and when to do it. We want to provide teaching so that the family is better able to care for their child in an outpatient environment. If we don't teach our families well, their child's going to be in the hospital much more than they need to be, instead of out in the world with their peers, which is where they grow emotionally and intellectually. Finally, I just wanted to encourage or add this in there. There's pictures in your book, and so I'm not going to spend a lot of time talking about this. But newborns are sometimes born with their bowel on the outside of the body. It's called either an omphalocele or gastroschisis. Uh, they are two different entities. They don't really know, they're still kind of questioning how a gastroschisis comes, but omphalocele is very similar to a hernia, except that it's bowel that's going up into the umbilicus and then breaking through that Wharton's jelly so that it just comes spilling out into the amniotic fluid, which amniotic fluid tends to be acidic, and so it's very harsh on the tissues of the bowel that are sitting out there floating in the amniotic fluid. Omphaloceles are more associated with genetic disorders, and gastroschisis tends to be not as strongly associated with other deformities. Uh, Basically, when these kids are born, the two major things that we have to worry about is keeping them warm and decreasing infection. So usually as soon as they're born, we get them wrapped up. We actually put them in something called a bowel bag. When they do bowel surgeries, they put the bowel into a plastic bag that helps keep it warm. And usually it's kind of laid off to the side. So these bowel bags are like a very large Ziploc bag, except it has like a tie at the top of it. And so we put the kid, like their whole body, into it. And usually we will try to wrap the bowel in a non-adhesive uh, type of dressing and make sure that there's normal saline on that so that the bowel doesn't dry out prior to surgery. So it's an interesting thing. They lose fluids very quickly because there's no skin covering that bowel. And so they often are written for very high volumes of fluid going through their IVs because of that. And I just wanted to mention that because after hearing that you didn't hear about some of these other things, I figured you may not have heard about these as well. And it's just kind of an interesting GI problem. And that completes this part of the lecture that we would have had. Talk to you guys soon. Bye.